A lot of patients, attendants, we tell them that if they're getting stuck, just put your foot in forward. They just have to cross your foot. And once they cross it, they can just start walking. So they need just an obstacle, small obstacle. But at the same time, it doesn't mean if you do, suppose a doorway or you have you have some crossing which you have to cross over, they may not be able to do it because the doorway is narrow. But if you have a small obstacle, they can usually cross it better. Right? So there are people who have painted their houses with black and white squares or lines, so that just for the patient to just walk. So they find it very easy. Symptoms start. So a patient with Parkinson's disease may have constipation years before he starts to have tremors or slowness, or he or she has tremors or slowness or rigidity. They can have loss of smell, and they can have a disease called as RBD, which is called as REM sleep behavior disorder, means dream enactment. They tend to speak in their sleep, or they tend to move their hands in their sleep. They have some weird dreams or some strange dreams where they are enacting the dream. So they may be running away from a thief, or they may try to hit a thief, and they can tend to hit their, the spouse partner, bed partners. And these can happen before the motor symptoms start. A combination of these three, if you have olfactory loss, you have restless leg, REM sleep behavior disorder, and constipation, there's a 90% chance that the patient will develop Parkinson's disease. By itself, singly, it's not a major problem. But in the combination is like that. So these are pre-motor symptoms. We call them as pre-motors. But after motor onset, or the tremor, or the slowness, or the rigidity, you can also have other symptoms like memory disturbances, delusions, means that you have a doubt about somebody, or you can have hallucination. You have look at people, it feels like there's somebody who's come in and gone out. And you can have memory disturbances when they cross around 20 years of disease. The only silver lining in this thing is that if you have a young onset Parkinson's disease, you are probably going to develop memory impairment much later. So people have seen it's most likely that if you have more than 80 years of age, that's when the memory impairment happens. It doesn't matter when you develop the Parkinson's disease, it may be at 70s or 60s or 50s, but think by the time you reach your 80s, you may have memory impairment. So it's not that everybody will develop a memory disturbances. Autonomic disturbances can be there, that is that they can have constipation or drooling of saliva. They can have BP drop. So when people get up suddenly, BPs can drop. So you have not only with the Parkinson's disease itself, but the medication also can cause a BP drop. So if somebody is complaining of giddiness when they're getting up, it is better to look at what medications they are on and making sure it is not just a BP drop which is causing them the problem, and not label them as saying, oh, Parkinson's disease, so they're tending to have giddiness. They can have a lot of sweating, which can happen. So this is one patient who had very severe sweating. You can see the photo which is there. He used to carry a tablet of Syndopa in his pocket, and every time that he would go off, it would sweat so much that the whole tablet would, it would run off, and he had this permanent mark on his all his pants and all his shirts. But this is something this is usually something when you don't take the medication on time. These are all called as off times. Sleep disturbances can happen, and it's very important to again note the sleep disturbance, because if the sleep is good, the motor symptoms also improve quite a bit. So you should always be careful about the sleep disturbances. Constipation, sleep disturbances, these are treatable parts. So once you treat them, the patient improves well, not only in these aspects but also in the motor aspects. So that's why it's important to know the non-motor symptoms. If the doctor is not asking you about them, even then, if you have any of these problems, you should bring it to the notice of your doctors. But these are the problems which are there, because they're not seen on the patient. So these are something which is only being dealt by the patient. Pain again is quite severe sometimes, so you can have pain in the nights. Patients can have problem in the sleep because they are not able to turn around in the sleep, increased amount of urination in the sleep, and pains because they have stiffness in their body. So all that are very important aspects to be again thought about and see why they happen, and if they happen, how to treat them. How do you diagnose? There's no specific diagnostic test. There are diagnostic tests, but to prove that it is only Parkinson's disease, we usually require a brain biopsy, which we don't do. Most of the times we just rely on the symptoms and the fact that they respond to levodopa. The response to levodopa is so marked that you know that you have Parkinson's disease if you are responding to the medication. So So that's more than enough to usually diagnose. But you have these scans which are now available called as F-DOPA PET scans. If there's a doubt, usually patients are we can undergo, or there's something called as TRODAT scan or DAT scans in the US, where TRODAT in India. So these scans can help you diagnose if you have a doubt between, say, some other form of tremor and Parkinson's disease. There are some symptoms, some group of disorders which are called as Parkinson plus syndromes, where it's not just pure Parkinson's disease, the protein which is being deposited is completely different. So in that kind of patients, or where the deposition of the area is very different. So in that kind of diseases, you can do something called as an FDG PET scan. So these are tests which may be done to differentiate between Parkinson's disease and Parkinson plus syndromes, atypical Parkinsonian syndrome. So these are something some can help us diagnose. So just I again don't want to go too much on this, but this is what happens. This is the substantia nigra pars compacta, which is supposed to produce the dopamine. You have both inhibitory stimuli and a stimulatory stimuli. And when it comes to the thalamus and to the brain, this is the signal. So when this gets damaged, you can see that there is a lot of inhibition on the thalamus, and the signal which is going to the brain is very thin. So if you want, so what I'm trying to say, suppose I want to move my hand from here to here, the brain receives a response saying that this is the amount of movement I have to do for it to move from here to here, and it sends that information to my spinal cord and to my muscle. In Parkinson's disease patient, the signal that comes up is only this much, the thin one. So it only sends that much signal to the spinal cord. So it will only send signal for me to move up till there. That's why the patients cannot move it as much. So that's why they become slow, and the range of movements becomes less and less. So this is actually what we think is the pathophysiology of Parkinson's disease. How do you treat? Treatment of Parkinson's disease is only symptomatic. We are definitely looking for a cure. Everybody is looking for a cure. There's so much of money being spent in. We hope that it will be found, because there's so many diseases where the cures are getting found. So we hope that it will happen. In the meantime, please don't go for stem cell therapy or things like that where you say, okay, there is an instant cure. The stem cell therapies have been tried in Parkinson's disease, have not been proven to be beneficial. The only stem cell therapies which have been proven to be of somewhat use is using a normal dopaminergic neuron stem cells from, say, we call it as mesenchymal stem cells, from the lab or from fetus stem cell, from the cord blood, and then inject it into the brain using a surgery. And that is where there has been some benefit, but even there they could not regulate the amount of dopamine. So once the stem cells were injected, they became worse and worse and worse, and they had a lot of other problems afterwards. So this was all in 80s and 2000. The stem cell therapies which are available today, where you just take blood from the bone marrow and inject it into the stream, has no sense, or into the spinal cord, no sense. So please don't waste your money on stem cell therapies in Parkinson's disease. If there is a proof, it will come out. So once it comes out, then you can think about it. Right? It is still symptomatic, and the main symptom is that, I've been talking to you for almost half an hour on this, saying that it is the dopamine, which is dopaminergic neurons, which are getting damaged because of the accumulation of alpha-synuclein. So obviously there's a reduction in the dopamine in the brain. So what we do, the most of the medical therapy is actually to increase the dopamine level in the brain. That's what we do. All the medicines are like that. So first medicine which is used is something called as levodopa. Levodopa is a dopamine agonist, which means that it is not just dopamine. So once you give the dopamine into if you suppose take oral dopamine, it will get metabolized in the stomach itself. It won't go into the blood at all. Even if you inject dopamine into the blood, it will stay in the blood and not go into the brain. So you have to give a progenitor of the dopamine, so which is called as levodopa, and that levodopa is given along with a tablet called as carbidopa. So when they are combined, it prevents the breakdown of the levodopa in the blood, and all the levodopa goes into the brain. And once that goes into the brain, then you can have the levodopa is again broken down to dopamine, and the dopamine level increases in the brain. So this is how the medication acts. So this levodopa carbidopa is what we see like syndopa, LCD. So these are the things, and I'll again come back to them. So it's usually given in the combination of 1:4 or 1:10. So I don't know whether the next one. Okay. So this is like syndopa plus or syndopa or LCD, or you have Tidomet Plus. These are the common Madopar. These are all the brand names which are used for levodopa carbidopa combination. Now there is a kind of a misconception in most of the patients that when you take Syndopa Plus, which is 125 mg, that is more potent than Syndopa 110. Actually, that's not truthful in the correct sense, because both of them contain only 100 milligrams of levodopa. The 10 milligrams is actually the carbidopa, or 25 milligrams is the carbidopa. So Syndopa Plus has got 25 milligrams of carbidopa, Syndopa 110 has got 10 milligrams of carbidopa. So when do you use these two? Actually, strictly speaking, Syndopa Plus, that is 25 milligrams of carbidopa, should be started initially. You require around 75 milligrams of carbidopa to completely prevent any breakdown of levodopa in the blood. So initially when you start with 3 tablets of anything, so it's better to go for Syndopa Plus or Tidomet Plus or LCD 125 rather than going for the 110 milligram dosage. The 110 milligram dosage is useful when you are giving a higher dose of, say, the medication. So you are taking some 6 tablets or 7 tablets of levodopa carbidopa combination. You don't want so much of carbidopa, so you bring it down to 110 milligram. Normally, people have tried it in different formulations, but this is one of the things that it is preferable to use a 100 plus 25 milligram. The other thing is that this medication should always be taken in empty stomach. It should not be taken with food. It will not work with food. So at least half an hour to 1 hour before food is important. If you take it with food, it prevents the absorption of levodopa carbidopa, and there will be no effect. So it's usually given 3 times a day to 4 times a day. So when you give it without food. What are the side effects of levodopa carbidopa? It can cause nausea and vomiting. That's where the problem comes in. So you start on taking levodopa in the empty stomach. You can get gastritis, you can get some gastric irritation, get some nausea. So what do? You can have a little bit of food, maybe a biscuit or a little bit of coffee or a little bit of milk, and then take the medicine. That's it. Not on a full stomach again. So just a little bit of food can actually prevent your gastric irritation, nausea, vomiting can come down. Drowsiness, it can cause. A lot of people feel that after taking these medications they tend to sleep and then they become better, but it is little less. If you give higher doses, it can cause psychiatric manifestation. But out of all the medications for Parkinson's disease, levodopa carbidopa is the safest in terms of hallucinations or confusion. Older the individual, it is preferable to start with levodopa carbidopa rather than starting with other medications. It can cause wearing off. So what do you mean by wearing off? It's like initially when the patient has Parkinson's disease, they have a honeymoon period. You take levodopa carbidopa 3 times a day, the whole day you're fine. There's no problem. Afterwards, the effect of the levodopa carbidopa becomes shorter. So you take a tablet, it will only last for 4 hours or 3 hours. And then once it comes down, then you again have to take another medication. This is called as wearing off. So it's called as motor fluctuations, where you can have on-off phenomena. And then you can have, you can have something called as dyskinesis. Again, I'm not sure whether I can see it, but I think most of you know what dyskinesias are. Anybody in the audience who doesn't know what dyskinesias are?
Repeat the question, please.
Sorry? No, the dyskinesia. So there are two. So what happens is when you take levodopa carbidopa, after a while, you can go from low movements, no movement, to high movement. Okay, it's there. It's coming on. Sure. So this is what is called as dyskinesia. This is extra movements. Contrary to what is seen, people think that they are suffering at this point. But most patients find it better during this period. They are more freer. Not the severe dyskinesia, but the small dyskinesia. They are actually more freer at that time. So this is more worrying for patients who have dyskinesias. For patients, attendants rather than for the patients, at least in the initial stage. But in the later stages, you can have very severe dyskinesias which can cause them to get injured or harmed. So that time you have to reduce the medication. So there are 2 types of dyskinesias. One is called as peak dose and biphasic. Peak dose means the dose when it becomes high, they can have very severe dyskinesia. So the easiest way is to reduce the dose of the medication. Means that if you're taking 1 tablet of Syndopa Plus or Tidomet Plus, make it 3/4 or make it half. The dyskinesias will come down. So you can take it the same number of times. Some of them unfortunately also have something called as biphasic dyskinesia. That is when they're just becoming off. So again, I don't know how many of you understand what is off and on. Everybody understands what is off and on. Off means when the medicine is of no effect. So they have tremors, they have become rigid, they are stiff and they are slow. On is when the medication effect is completely there. So they are like very happy and they are actually able to do everything. There is a scoring system called as UPDRS score. The reason why I am trying to tell you is that Parkinson's disease patients become normal with medicine. I mean, near normal. It's like it is not. So you have something called as UPDRS score, which is actually a score of 140 points. The more the disease progresses, the points are going to increase. But this dose, most of the times, with most of the patients, the score will come down to less than 10 when they take the adequate amount of levodopa, carbidopa. That means they become almost normal. So they're able to do everything when they're on. And this effect of medication, making them on, stays almost throughout their life. Very rarely is it that the on doesn't happen. If the on doesn't happen, you have to think that you have a different diagnosis only, not Parkinson's disease. So that's why we diagnose based on it. So you give levodopa, carbidopa, they're just completely up and about. You must have seen videos of apomorphine. I'm sure you must have seen patients with DBS also, surgeries, where they will show one patient who is like completely dull. The moment the injection gives in, they are completely pumping up, they are doing some hand pushes or hand up and down and they are running around. The same thing happens with levodopa carbidopa. It is a medicine, the dopamine, which makes a difference. Right? I just want to clarify. So the thing is that only problem with levodopa carbidopa, so it's a very good medicine. There's no problem with it. But only issue is that when you give an oral tablet, you can't give a continuous level in the brain. So what happens is it go up and down. So basically once you give the tablet, the level goes up, and then once every time the tablet comes down, it actually crashes. So even if you take it like every 1 hour, 2 hours, people have taken it every 1 hour also. Even then they will have this on and off. It's called as motor fluctuation. So they become on, which means they're completely good. They do all their activities in their on period. Off when they become done. Right? So what can we do about it? There are some medications which can improve the So what we can do is, let me go for the opicapone. And so there are some medications which can actually improve the duration of the action of the levodopa, which are called as COMT inhibitors. I'll be talking about it a little later. Entacapone and opicapone are commonly available. There is some hope that we will get some new formulation with levodopa carbidopa only. There is a levodopa carbidopa gel, duodenal gel. So that I think everyone now here is very clear that levodopa carbidopa is a drug of choice. It actually was considered a miracle drug for Parkinson's disease. Till that time there was no treatment only. So once the levodopa carbidopa came in, it was like a revolution. It's like everybody was like, wow, it's like such a miracle has happened. The only problem is that you need a continuous supply of this dopamine into your brain. We can't give it with the oral tablets because they are not really staying long enough. So there is something called as a levodopa intestinal gel, which you can actually put a tube into your duodenum and continuously infuse the medicine into the duodenum. But the problem with the levodopa gel is it costs 26 lakhs per year, which is impossible for, I think, anyone of us here. But there are some hopes in the sense that there is a possibility that we may get an injectable levodopa carbidopa, which is right now in the pipeline. There's an inhalational levodopa carbidopa where you can just take a puff, and the moment you're off, you can probably become on, which would be really good. But these have not come into the market. They're just being tried out in the US market. Imbrija has probably come out already, but it is just on the whole, it's coming up. So that is with levodopa carbidopa. So what are the other medications which are used? So these are the dopamine agonists. So the reason why dopamine agonist has come into the picture is that when you have levodopa carbidopa, not just do you have on and off, you also develop this dyskinesia. Dyskinesia, as I told you, is that the drug so what happens, the brain is waiting for the dopamine. So it is becoming very, very, very sensitive. So you give a small dose also, the brain just goes into an overaction. So it's like the movement just goes haywire. So the dyskinesias are seen much more commonly in youngsters compared to older people. And so that is why people actually prefer to use dopamine agonists, which is long acting, not as effective as levodopa carbidopa, but really still give us a benefit. So these they look like dopa. They're not actually releasing dopa, but they look like dopa. They go and sit on the receptors which are there for the dopa, and they act the same way as the dopa. So there are a lot of dopamine agonists. There are ergot derived and non-ergot derived. Right now, most commonly we use these non-ergot derived, propinerol, pramipexole, rotigotine and apomorphine. The ergot-derived are all older ones. I don't know, some people might be using Parivarthan LA. These are all ergot-derived, pyramidal. So those kind of drugs. Otherwise, most people would know about propinerol, pramipexole, rodigotina, and apomorphine. They're similar to levodopa. They have also the same side effects like nausea, vomiting, postural hypertension, confusion. They can have very severe drowsiness. So it is important to ask a patient who's put on pramipexole or propinerol or apomorphine whether they're getting sleepiness. So there have been accidents with car driving when the patients have been on the medication because they just suddenly went into sleep when they were driving the vehicle. So that kind of sleepiness can happen. Not for all the patients, but for some patients. So these are the side effects. Sometimes you can have pedal edema, swelling of your feet, which is not related to your kidney or the heart, but can be related to the medicine. So again, it causes a problem, but you have to know that these are the side effects which can happen. Ergot has been now more or less stopped because it causes a lot of fibrosis in the heart and in the cardiac evaluation. So people have just stopped using ergot. So only non-ergots are being used. Now this is something which everybody needs to know and everybody needs to talk about. Because this is something, it's like a social stigmatizing behavior. It's just a side effect of the drug, which are dopamine agonists, which is called as impulse control disorders. So these are a group of disorders which are like pathological gambling, hypersexuality, compulsive eating or shopping, punting and excessive hobbyism. These can happen. And we've had this misfortune that patients tell us only much later. So we've had patients who come back and told us, my husband always gambles. He's lost so much of money in the gambling because he's got Parkinson's disease. My wife my daughter had her wedding and my wife bought fairness creams for all the maids in the house, telling them that they have to become more beautiful. It is not a relation to that. She just wanted to buy it, she bought it and she gave it. So these kind of things can happen and they look very silly and they don't look related to the disease, but they're actually related to the medication. They're not a part of the psyche of the patient. Patient is not at fault. Hypersexuality is also quite common and this can be very abnormal when it is seen in elderly people especially. Because the spouses cannot talk about it to neither their children or the other relatives, they can't tell it to the doctors. So these are things but you need to know about it because you have to tell it to the doctors. So if you know about it, then you can tell them and then they can reduce the medication. These can cause a lot of problems. Compulsive eating can happen. They can have something called as a funding or they can have something called as a dopamine dysregulation syndrome where they tend to take medication. Some patients are like that, they're like, I need a medicine at this point. Whatever medicine is available, they'll just pop in because they've got that's again a side effect of the dopamine agonist. So they'll just pop a pill because they think that at that point they require the medicine. May not require it at all. There's one patient of ours who actually took a clonazepam, sleeping tablet, just because she thought that she needed to take the medication at that point. Some medicine, it doesn't matter what medicine. So these are side effects which can happen and these are some things which have to be told to the patient, the doctors. Again, I'm emphasizing the fact because it's difficult to bring these things up when you are meeting a doctor. Maybe you can talk to your, in the support group, and it will be better. So this other thing which is dopamine dysregulation syndrome with dopamine agonist, especially with pramipexole which has been seen, that you can have a very high level of having impulse control disorders. Young people are more prone. The other drug dosages which are present are something called as a MAO-B inhibitors. Now, till now we have looked at dopa agonist, which is looking like dopamine agonist. The reason why dopa agonist causes this kind of a problem is because it does not stimulate only the substantia nigra, but it also stimulates another part of the brain called as the limbic system. So that is why. So it's not very specific to the disease area. So that's why the dopamine agonist also causes this problem. Mono B inhibitors are the ones which actually prevent the breakdown of levodopa. So this increases the dosage of the action of both the dopa as well as the dopamine agonist. And these are the main drugs which are called as selegiline, rasagiline and zephaninemide. The reason why we use them is that there is some possible neuroprotective effect of these medications. So most doctors would prescribe one of the three when you immediately first time go to the patient, to them for diagnosis of Parkinson's disease, because it's not proven, but it looks like that if you take the medication, the progression of the disease may become little less compared to otherwise. It also has its own side effects like nausea, lightheadedness, constipation. The confusion is less compared to what happens in dopamine agonists. Dopamine agonists can cause a lot of confusion. Hallucinations can occur especially with elderly patients. So the COMTs, which are actually drugs which are actually causing which increases the metabolism. So once if you have a patient with levodopa, carbidopa and they are not continuing the medication, you can actually give them, I mean if the on time lasts only for 1 hour, you can give something called as opicapone or entacapone. I'm sure a lot of people probably use syncapone where the duration of the drug is helped. The next management which comes is anticholinergics. Now, anticholinergics are like pacitane, parking, trihexyphenidyl. It's actually trihexyphenidyl is a dose. So in the brain there's an imbalance between the dopaminergic stimulation and the cholinergic stimulation. So once the dopaminergic stimulation comes in, the cholinergic stimulation is also reduced. So that's why it is called as anticholinergics are given. But these are not given to be given in the elderly because it can cause a lot of problems like hallucination, urinary retention, worsening the constipation. It works extremely well for patients with tremors, but it comes with a lot of side effects. A lot of the Western world don't use it. Amantadine is something when you can give when you have dyskinesias or when you have gait disturbances, you can give amantadine. Again, it also has a lot of side effects like confusion, hallucination, swelling of the ankles and such. So the most of the patients who are on Parkinson's disease, we normally prefer to give them levodopa. This is a rough slide, it's a busy slide, I don't think you can see, but basically how much does it improve each of the medication based on, how much does it improve the on time. Non-motor symptoms, as I told you, every non-motor symptom has its own treatment. So constipation, you can get some laxatives, sleep disturbances, you can give melatonin, urinary problems, you can have solitanosin, cognitive impairment, if there's memory disturbances, you can give something like rivastigmine, which may improve your gait also. So these are things which has to be treated with medication. So what happens with Parkinson's disease is that usually 0 to 4 years is the good years, then you have a progression, and then you start developing dyskinesias. So once you develop this, you have to think about what is the next step. So I'll stop here because the next step would be to think about either apomorphine or deep brain stimulation or continuous enteral development stimulation. But what I want to tell you is that this doesn't mean that you stop the medicine. See, medicines for Parkinson's disease is going to go on lifelong. So you have to continue with the medication. Apart from the medicines, the rest that you have is that you have to have physical therapy, which has been spoken. Of all the treatments which are there for Parkinson's disease, currently the only therapy which has some effect on preventing the progression, which has been shown without fail to prevent the progression of Parkinson's disease, is physical exercise. So that is very, very, very important. Every patient with Parkinson's disease should start their physical exercise. Right. So thank you, and I think I may not be able to take the questions here, but I'll probably take it.
Are there any questions? If we ask, then it will take time. If you have written down the questions, volunteers will come and collect it. Please collect the questions, hand it to me, I'll ask it. I'm just going to use my discretion in asking each question because we are really out of time. What I'm going to do is I'm not going to ask specific people. Sometimes say I'm taking this medicine, should I reduce the dosage? So those are like individual consultations that we can't do now, but I can ask some general questions. Okay, what are any specific problems faced by women due to Parkinson's?
Nothing actually specifically. There's not much of difference between women with Parkinson's disease and men with Parkinson's disease. Both of them have the same kind of problems, but then women tend to have more gait disturbances and they tend to become more wheelchair bound, basically because of the associated osteoarthritis and other comorbidities compared to men. Cognition, brain wise, women have lesser cognitive problems. Actually, they are more sharper till the end compared to men with Parkinson's disease who develop cognitive impairment. So these are the differences.
This is a question I'm going to ask quickly because it's an easy answer. Can you talk about non-invasive deep brain stimulation? Deep brain stimulation is invasive, it's not non-invasive,
Right.
and it's a huge topic by itself, no, doctor?
Yeah, so I'll just tell you that there are some transcranial magnetic stimulation or transcranial electrical stimulation, but the problem with these stimulation is that their effect lasts only for the time that they're given. It's not like a continuous. So you take the stimulation, you're better for some time, and then again the effect wears off. There is something called as a high frequency ultrasound therapy where you can ablate the lesion, but the problem with that is that you can only do it on one side. So you don't have to undergo surgery, but you actually send a laser inside to damage it's not a laser, it's an ultrasound which is actually sent to damage one part of the STN, which again is good for tremors, which are essential tremors, rather than for Parkinson's disease.
This is a good question. Does Parkinson's tremor begin in patient's dominant hand, that is left hand versus right hand, and the progress?
No, it doesn't. It doesn't. It's not dominant. It just starts in one hand. Some people have it on the right, some people have it on the left. Yes, countryside tube wells or chemicals can cause PD. Again, there are some studies which have come from India only, which again, as I told you, it is just a comparison of people who have taken well water, who have Parkinson's disease, and then we have gone back. Not like you don't start with well water. It's not like you start with a child who's got drinking well water and find out whether they have Parkinson's disease or not. So we don't know for sure.
But yeah, if there are exposure to too much chemicals, then
yes,
proclivity to Parkinson's is high. Somebody asked, is Parkinson's contagious?
No, not at all. No.
Oh my God, if it was, imagine all of us sitting in this room.
It is hereditary in a short subgroup, 20% is hereditary, but the hereditary Parkinson's disease happens in the younger people. Means that they usually have the onset of symptoms starts early, not late. That may be there, but that is less likely, less common, maybe possible. So there are, I'm just giving a very broad overview. So 1% older individual can have hereditary Parkinson's disease. Most of the hereditary Parkinson's disease, the monogenic form where you know that this gene causes this, is younger people. Younger.
There is like some personal complaint.
But that doesn't mean that everybody who's younger has got a hereditary Parkinson's disease.
Yeah. Patient is not willing to take medications properly, is very stubborn, poor decision making ability, does not cooperate with caregiver. Yaar sir, romba complaint pandringa patient patti. Enna pannalam, doctor?
There are psychiatric illnesses are associated with Parkinson's disease. Depression, anxiety can be there. You need to have the patient brought to the counselor or a psychologist so that they can discuss with them and then decide. Lot of patients they are stubborn and they don't take medications well. But it also is true that with Parkinson's disease, the medicine is so beneficial that 95 to 98% of them will take the medication just to feel better. They know that they will feel better with the medicine. So we don't really see so much of non-compliance.
Sorry. Another good question. How much protein can be given ex-paneer protein supplement? Because Syndopa does not react well with protein.
Yes, so the thing is that you can take protein. It's not that you should stop the protein. Normal amount of protein needs to be taken. We advise the proteins to be broken down into small parts and give the maximum amount of protein in the night rather than in the afternoon, because when they're sleeping they can take the protein and then they can be okay. It does prevent protein does interfere with the absorption of the Syndopa, but you need protein to survive. It's just that we can't stop the protein. Or you can take an extra dose of Syndopa in the morning before the breakfast or before the lunch.
What is this impact? What is this?
The connection between food intake and Parkinson's, we don't have a clear-cut diagnosis like that. There are some gut bacteria which have been shown to be associated with Parkinson's disease, like Helicobacter pylori infections, which is happening in the stomach, can be an association with Parkinson's disease. But these are just small associations, not really clear. So with food, nothing much. There is no clear-cut food which causes or which prevents Parkinson's disease. Medication cannot be given with food because it will prevent the absorption of food, prevents absorption of medicines. So that's the only correlation.
This just seems like a very general question. My mother has Parkinson's from 2018. She's 84 years now and they are given the medication that her mom is on, but there is really no question. So as I said, we are not encouraging any person because it depends on the person, and doctor cannot give an opinion on whether this prescription is alright or not.
That's true. Speech and talking, you need to go to a speech therapist. Exercises to improve the speech is very important. Singing, shouting, laughing can all improve the speech. So the other thing that which is very interesting, is that if you are using your mother tongue, your speech is going to be worse. If you use a language which is not so easy to speak, your speech is going to be better because it's going to be focusing on the speech. So you can probably try that out and tell them to focus more on their speech.
There are many questions by one person. We'll take maybe one question. Take this. This is interesting.
When patient develops early symptoms of PD, does F-DOPA PET reveal the problem? Yes, F-DOPA does give you a diagnosis of Parkinson's disease. Dopamine agonist CMT to control dyskinesias. They are better if you are reducing the levodopa. You give dopamine agonists, MAO-B inhibitors and CMT inhibitors, and reduce the dose of levodopa carbidopa. Then the dyskinesias do come down if you have a peak dose dyskinesia. Yes, MAO-B inhibitors are given in the early stages of Parkinson's disease itself. As I told you, the only reason why we give it is because we think that there is some neuroprotective effect. Means that if you give it early in the disease, it may slow down the progression. May is a word.
We'll just take a couple of more questions. We'll have to wrap it.
Skin problem, no connections. No, varicose vein skin problem, there is no connection. Seborrhea, seborrheic dermatitis means dandruff, is a very common association with Parkinson's disease. So if you have, you may have to take treatment. It can be quite bad. So you may have to take oral therapy or proper, local therapy, medications for the scalp for you to prevent it. Vitiligo or that can also worsen with Parkinson's disease. Eczema sometimes worsens with Parkinson's disease. Psoriasis sometimes worsens with Parkinson's disease.
Did you mention about transcranial magnetic stimulation, doctor?
As I told you, transcranial magnetic stimulation has been shown to have some benefit, but it is only for the time. So it's like transcranial magnetic stimulation is given in cycles of 30 minutes. So if you take it for 30 minutes, that day you are better. Again, you have to take it the next day for 30 minutes to become better. So it's not being shown that you take transcranial magnetic stimulation, you are much better like 3 months later. So that's the problem with transcranial or magnetic or electrical stimulation.
I have taken antipsychotic drugs for my anxiety disorder for past 5 years. Currently stopped the medication. Do I really get Parkinson's in the future? Can I diagnose now?
Antipsychotics cause drug-induced Parkinsonism. It doesn't cause Parkinson's disease. It can, if you already have Parkinson's disease and you are taking antipsychotics, it can make your disease manifest. But by itself, it does not cause Parkinson's disease. You can make a diagnosis now by using an F-DOPA PET if your Parkinsonian symptoms are really bad. Otherwise, the best option is just stop the antipsychotics for some time, see how much you are improving, and then take a call on it. Not just the antipsychotics, there's one more drug which I want you to all be very careful about. It's called as levosulfuride, L. In the antacids, it's called as Pantocid L, Homase L. That levosulfuride can worsen Parkinson's disease, can cause Parkinson's-like symptoms. So anybody who's on it, please stop. If you are having Parkinson's disease, I would not advise you to be on it. It's a very good drug to improve gut motility. So a lot of people who are belching are prescribed that medication, but it can cause Parkinson's.
We didn't know that. Thank you, doctor. I think this question seems like from a yoga teacher. Yoga therapy is much more effective than physical therapy. Why do doctors still promote only physical activity and not yoga? Well, somebody is rooting for their profession here.
No, the yoga. No, this is not true that we only prescribe physical therapy and not yoga therapy. Physical therapy is actually easier to generate a lot more videos. I'd really love your yoga teachers to actually make modules and bring it up. We have a yoga teacher in Parkinson's Society in Hyderabad who gives online yoga sessions all the time. Dr. B.K. Iyengar. Yoga has been proven to be extremely beneficial. But the problem with the yoga is that it's like even for physical therapy, you need to have 1:1. It's not a generalized format. So each patient will have a different kind of a formulation which they have to undergo. I'm sure that yoga needs to be promoted a lot more. I think the yoga teachers should promote it much more.
Yes,
We are all waiting for you. If you are happy to give us yoga sessions in PSH also and in Parivarthan, I'm sure they will be very happy to take it across.
We do have customized yoga therapy intervention. Saravanan, I see you asking the question and smiling. Yeah.
Yeah. Can non-pharmacological therapies like mindfulness? Yes, it does. Mindfulness does help prevent, not the progression of the disease, but improve the disease itself. So we tell the patient two things. One, you be happy, which is very important. The more happier you are, the better your symptoms are. The progression is going to be comparatively less. I'm sure everybody here will agree. When he was speaking, heckling or somebody telling you that this is why are you moving so much, will actually cause them to move more. It doesn't help them out. If they're more relaxed, if the Parkinson's disease patients are relaxed throughout the day, definitely the progression is going to be less. Happiness and relaxation is very, very important. So mindfulness is definitely important.
I think every profession is having their say here. I think another one is from occupational therapy has a major role in Parkinson's disease. Yes, we are mentioning, but doctor, please.
No, I'm sorry. I didn't mention it because I just was talking about the medical therapy of Parkinson's disease. But occupational therapy, psychologists help, counselors, physical therapy, yoga, everything is important. Dance therapy, art therapy, everything.
Doctor has mentioned all therapies in case there are therapists here who are saying, why are you not mentioning our therapy?
They're very important. Occupational therapy is very important.
Very important, yes. And our counsellor Vijay Lakshmi is here. Yes, counselling is one of the most important things that caregivers need more than the.
But I just want to know how many occupational therapists are here actually.
There are quite a few of them are here today. That's why I think this question came up.
Nice.
They are there somewhere.
That's good.
Yeah.
Because we seem to have a lack of them in Hyderabad. I want to find it. That's good.
I just one quick wrap up. We have heard today a lot from Doctor about what it does to a person when somebody has Parkinson's. So if you see somebody walking slowly in front of you in public or struggling to eat, let's all be kinder and nicer to them. And having personally seen so many members with Parkinson's, I can say that it usually robs them their ability to speak, walk, express themselves. But from all my members sitting here and the new ones, I'm sure from Narasimhan sir, here Singaran sir, Sendilagan sir, their spirit and their kindness, and Dr. Shanti Priya here herself, their amazing sense of self, no disorder robs them of that. They are such amazing individuals who have had extremely great lives that they had before Parkinson's, and they carry so much dignity in them even after the disease. So really, we can talk here as much as we want, but they carry it so beautifully. So thank you, doctor, and thank you to all our members. Mr. Singaran, please come up and introduce Dr. Shanti Priya for us and hand over the memento to doctor.
The Parkinsons ரொம்ப கஷ்டப்படுறாங்க, நினைப்பாங்க, பேசுவாங்க. ஆனால் அப்படி இல்லை. Here in our group we have a beauty queen. She has won beauty contest and she has been known as a beauty queen in Singapore also. She is a young onset Parkinson's warrior and qualified doctor, and a qualified doctor, a writer, an amazing self-taught artist who deals with Parkinson's with determination. She is running her own non-profit to help people with PD called SAR Foundation, SWR Foundation, SAR Foundation. And I remember about 5 years back, she conducted a marathon and then to know the PD is in India and Chennai. There was a very good crowd for the marathon. And I'm happy she gave me a chance to act in a video film she took, and I was given a chance to act in that. It has been such a pleasure to know her, and yeah, she is none other than Dr. Shanti Priya. So I request Shanti Priya to honor our Dr. Rukmini.
Please come this side, madam. Please come. Okay. Come here. Just show.
Thank you for the lovely introduction. Art has helped me a lot. It's a type of meditative process which helped me come out of I was also suffering from depression for the past 3-4 years, but art has really helped me to come out of it. And everybody should accept the disease and go on and shake off and move on.
I agree with that. I have Vidya Krishnan also here, who actually probably knows more about Parkinson's disease than I do, because she's been having the disease for longer than probably 25 years. But I just want to say that Dr. Shantipriya and Vidya Krishnan, they both are they are the models to be followed. See, it's like saying that you have BP or sugar. You have hypertension or diabetes, you don't actually just say, okay, I have some major disease. Parkinson's disease actually needs to be treated like that only. So that's what they prove, that they are playing, they are working, they are doing everything which is possible, probably much more than even normal people. So there is no restriction just because you have Parkinson's disease. There's a lot of treatment which are available. It is a disease, that's it. It's a simple disease. So many of us have so many diseases. It's a little, it seems, but the important thing, there's a question on what is the role of social worker. The first thing I think is to increase the awareness, which is actually very important to know that this is a disease, and it's just a disease. It's not something like a stigma or a problem which has to be hidden or which just has to be suffered through on your own. There's so many other people, so you know exactly how to go about it. So I would wish you all a very, 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 very happy life, active life from now on at least.
Is there any restriction for driving the car?
We have to wrap up. I have to first. I have a long list to thank, but I'll just stop with thanking Savera Hotel today for accommodating so many of us when I had given them half the strength will show up. And thanks also to the Hindu for sponsoring our ad, and hence all of you here. Please have some snacks, make yourself comfortable, talk to doctor, talk to each other, and talk to us.
Swimming cut பண்ணு. கை இந்த